Welcome to The Code Trade, a podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine ICU pharmacist at the Mayo Clinic. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Our last presenter is going to be Tom Szwajnos, a PGY2 emergency medicine resident from Advocate Christ Medical Center, presenting on the RAFF4 randomized clinical trial.
All right. Thank you, everybody, for that introduction. So I'll get right into it. Kind of the way I'm going to format this presentation is I'll go a little into the background for Afib and some treatment strategies, a little bit of the previous literature, and then dive right into the RAFF4 clinical trial. So going into atrial fibrillation, so this is a supraventricular tachyarrhythmia. It has inconsistent P waves on the EKG, typically an atrial rate of 350 to 600 beats per minute. And we look at this visually here on the right. You'll see on the normal sinus rhythm that the electrical conduction pathways are generally normal versus in the Afib pathways, they're going to be a little bit more disorganized or irregular rhythm. And so when we go on to look at our EKG findings, we'll see that our normal sinus rhythm definitely has those distinct P waves. And then when we look at our atrial fibrillation EKG, definitely see those inconsistency in the P waves and that very irregular rhythm overall. So there's a variety of factors that can cause atrial fibrillation, typically categorized by cardiac causes, systemic factors, or aberrant causes. So things like our cardiac causes are going to be hypertension or ischemic heart disease. Our systemic factors are going to be thyrotoxicosis or alcohol misuse, and our aberrant causes are going to be due to bundle branch blocks or Wolff-Parkinson-White syndrome. And to get into a little bit of the epidemiology, the overall population prevalence is relatively low at 1%, but you'll see that as age increases, the risk of developing atrial fibrillation also increases. So when we look at the elderly population, we see about a 12% incidence there. And that's also confirmed when we look at the young adult population, or those less than 55, where we see that less than 1% of that population is affected. So definitely an age-related disease. It should also be noted that for the most part, there's a higher incidence, prevalence, and lifetime risk in men, but we do find that the absolute number of women with Afib tends to exceed that of men. It's likely due to the longevity of women and more so likely that they tend to outlive a lot of the men who end up having Afib. So to go into some of the different treatment strategies, one of the options that we have is electrical cardioversion. So one of the things that we have to ask ourselves before we go either pharmacological or electrical is, how does the patient look and are they hemodynamically stable? If they have hemodynamic instability, then electrical cardioversion is going to be recommended right out of the gate. And then with that, we'll want to make sure that we synchronize to the R wave to avoid the risk of inducing ventricular fibrillation, which would be an additional problem then on top of their Afib. And then we're going to be shocking with at least 200 joules and then increasing energy requirements as needed. Other options are the pharmacological cardioversion strategies. So these are recommended by the American Heart Association, where we have a Butalide, a class 3 potassium channel blocker. It works relatively quick, but does have that QT prolongation risk, and of course then that risk of torsades. For amiodarone, another class 3 potassium blocker, widely used, has fewer contraindications, but the only issue that we find with it is that it has a longer time to conversion. So we'll be thinking sometimes in the realm of hours versus minutes. And then for flecainide, it's a class 1C sodium channel blocker and often referred to as the pill in the pocket approach. So this will be a single dose of an AV nodal blocking agent. And this can be really great for the patients that are out of the ED that know when they go into Afib, who then can take this and not even go to the hospital, but also has great uses in the ED as well. You may be wondering, where does Procainamide fit in this whole story, right? So the American Heart Association guidelines, as mentioned earlier, Butalide, flecainide, amiodarone are going to be actually recommended much above Procainamide. And really the way they word their recommendation is that Procainamide doesn't really fall into place unless you can't use any of the other first line options. So it's kind of a secondary choice when looking at our guidelines. And so why might that be? So I kind of want to walk through a little bit of the comparative efficacy. I pulled these 3 different trials that both compared Procainamide in general and then compared to other agents. So across the board, you can see that it's about 20 to 70% efficacy. For Kochiadakis in 2007, Procainamide did probably the best out of those 3 studies, but even then compared to propafenone and amiodarone, it still didn't do as well, where those were in the 80 to upper 80% ranges. And so the other way to look at this too is, what about the time to conversion rates, right? How fast are these patients converting? So it was very interesting because Kochiadakis actually had quite a substantially different conversion rate compared to Volgman and Steele, where they had it in the realm of 8 to 12 hours of procainamide taking about 8 hours to convert and amiodarone taking about 12 hours. But when we look at Volgman, it was about 30 minutes for both. And for Steele, it was about an hour before conversion. And the way they defined time to conversion, or their time frame for conversion, was for Kochiadakis and Volgman, they looked at it 24 hours from study initiation, and then Steele was any time prior to the discharge from the ED. So now I want to talk a little bit about Vernakalant. So this is a really interesting medication where it's a very atrial selective sodium channel blocker. And the really interesting thing about this particular medication is that it actually has increased atrial selectivity and affinity for the receptors as the heart rate increases. So as your heart rate gets faster, the medication should, in theory, be better. And the nice thing is that for the most part, the safety profile is relatively mild and transient with the infusion of the medication. So where does it kind of fit with us in the United States, and where does Vernakalant come into play? So we'll see from the timeline here that in 2010, Vernakalant had gotten European approval in Europe and has been used there ever since. In more recent years, it has gotten Canadian approval, which is where the RAFF4 study was conducted. And then, unfortunately for Vernakalant, both in 2008 and 2019, it went up against the FDA, and they voted against 11-2 against the approval of Vernakalant, citing some safety concerns. So a lot of the safety concerns that would come up would be bradycardia, hypotension, and even some reported deaths that they were overly concerned about. And so because of that, they had voted not to approve it in the United States. So looking at the different kind of profiles between Vernakalant and Procainamide, so for dosing for Vernakalant, it's going to be a 3 mg per kg IV infusion over 10 minutes, and that's going to max out at about 113 kilograms. Now, there's still an AFib after 15 minutes. You can do an additional 2 mg per kg IV dose over 10 minutes, and again, maxing out at that 113 kilograms. As mentioned before, it's got that atrial voltage-gated sodium channel blocker, relatively fast onset at about 8 to 11 minutes, and really great for that recent onset AFib and structurally normal hearts. Procainamide, on the other hand, we'll have variable dosing, but typically around the realm of 15 to 17 milligram per kilogram IV. The max dose, depending on where you look, of about 1,500 milligrams. The maximum infusion rate is going to be about 50 milligrams per minute. And the interesting thing about Procainamide is, sure, you'll stop for any major adverse effects, but if you achieve conversion in the time frame from when you started the infusion before the end of it, then you can actually just stop the infusion altogether. So this one's going to be a sodium channel blocker as well. And onset, as mentioned, it's going to be variable because it will, potentially be during the infusion or after. And this is a really great option for those with Wolff-Parkinson-White syndrome. Safety profiles are going to be relatively, for the most part, similar between both groups. We're probably going to see transient hypotension and bradycardia between both Vernakalant and Procainamide. Vernakalant, you might see more dysgeusias, sneezing, and paresthesias, where Procainamide, you probably won't get that as much. But overall, kind of a similar safety profile. So now going into some of the previous data, I wanted to talk about the Spectrum study. So this was done by Levi and colleagues in 2021. This was an international multi-center observational study. It enrolled over 1,700 patients who received Vernakalant for atrial fibrillation. And so what they found that overall conversion rates was about 72.1%. So this included those that had received Vernakalant and potentially some other medications that may have helped achieve that conversion rate. And then when they looked at Vernakalant alone, it was about a 70.2% for what they called the effectiveness population. And then when they looked at the adverse event rate, that was about 1.3%, with the largest kind of percentage of those adverse events being symptomatic bradycardia. And so it should be noted that with this study, with the large amount of patients that they had in this population, they did observe absolutely no deaths, which is good in favor for Vernakalant. So Bager and colleagues in 2022, they performed another analysis using the Spectrum ED data, and they wanted to take a look specifically at ED performance versus non-ED settings. And so what they found is that for both the ED and non-ED settings, about 2/3 of patients had converted at about 67 to 66%. And then for the conversion time, both saw conversion happening around 10 to 11 minutes, and were basically identical, again, between the ED and non-ED groups as well. And then for hospital length of stay, this is kind of where they really differ between the differences between the ED and non-ED cohorts. ED had a significantly lower hospital length of stay. For the non-ED group, you can maybe make the assumption that potentially these patients were sicker at baseline, they had more comorbidities. There was something causing them to have to stay in the hospital longer and potentially be admitted. And that's probably why we're seeing that difference in hospital length of stay. So the RAFF2 trial, this was done also by the same authors as the RAFF4 trial. So this was done by Steele and colleagues in 2020. What they wanted to do is they wanted to look at procainamide and electrical cardioversion. So they had this drug shock strategy protocol where they had IV procainamide at 15 milligrams per kilogram, followed by electrical cardioversion if they were unsuccessful or had hemodynamic instability. And now they compare that against the group that was the shock-only protocol, which is just immediate electrical cardioversion with no pharmacological options. And so when we look at that population, we'll see that the mean age is about 60 years old, about 2/3 were male participants, about 2/3 again had previous AFib, symptom duration of about 15 hours. And overall, you'll see that with this particular population, again, kind of mirrors what your typical AFib patient generally would look like, 60 years old, older, and male. But the thing I did want to point out too is that the initial heart rate was about 115 beats per minute, which all things considered is actually more on the low end and probably not what we consider rapid ventricular response. So that is kind of an interesting note to take from this study. So when we look at the trial results, you'll see that for procainamide alone, it didn't fare quite as well as the electrical cardioversion group, so about 52%. But taking it back to some of those trials that we had mentioned before, where we saw about 20 to 70% conversion rates for procainamide, it actually fits right in there. And Steele, who was responsible for one of those prior studies of procainamide as well, they saw these similar conversion rates of about the 50% realm. So now let's talk about the shock only and then the drug shock group. So again, pretty comparable. And so you might be wondering yourself, okay, well, electrical cardioversion seems to be the best answer. Why would we even want to do pharmacological cardioversion? But we'll see here that the drug shock group did marginally better by about 4% more. So you can make the argument that it is fruitful to try to pharmacologically cardiovert somebody. And if in the off chance that you fail, that you'll actually have a more successful electrical cardioversion. So in a way, by giving the pharmacological option first, you'll be priming the pumps to have the patient have a more successful outcome later on. So now let's talk about the RAFF4 clinical trial. So this was published very recently in November of 2025 by Steele and colleagues in BMJ. This was an open label comparison of Vernakalant versus procainamide. So their objective basically was they wanted to look at IV Vernakalant and they wanted to look at IV procainamide for the management of acute atrial fibrillation in the emergency department. So this was a 1-to-1 open label comparison. I'll talk more about this open label comparison that they use here. This was actually a specific reason that they used it was they wanted to mirror real world applicability. But outside of that, they had 12 tertiary care emergency departments across Canada and enrolled from June of 2021 to August of 2024. So they included all patients that had been in AFib for at least 3 hours, but didn't have it for longer than 7 days. They did have to be clinically stable. So if you think about it, it does make sense. If they're hemodynamically unstable, then they're going to be going for electrical cardioversion first and not be eligible for those pharmacological options anyways. Now, anticoagulation status obviously plays a role with this. So ideally, they want patients to be anticoagulated for at least 3 weeks, but if not anticoagulated for that period of time, then at least be low risk based on CHA2DS2-VASc scoring. Now, there were these other considerations too, where if the onset was less than 12 hours, then they didn't necessarily have to be anticoagulated. But then if we're in the 12 to 48 hour range, then they either had to meet equilibrability based on CHA2DS2-VASc criteria or show a negative TEE. So from the exclusion criteria and safety exclusions, you'll see that there's quite a lot going on here. And really what to dial it in a little bit is, anyone with permanent AFib was excluded, valvular heart disease. And it makes sense that they excluded patients who had AFib caused by an alternative condition, such as sepsis or infection, because it makes sense to treat the underlying cause for that prior to treating the cause or treating the AFib itself. Of course, they had to be hemodynamically stable, as mentioned, otherwise it would have cardioversion to begin with. Now, really to kind of boil this down simply is that these are your general exclusionary criteria that we'll see oftentimes in a lot of these different trials, but also these are probably some of the things that we're going on in our own checklist in our head when we're thinking whether or not a patient might be eligible for pharmacological cardioversion in our own EDs anyways. So for their treatment protocol, so they had an initial infusion of 3 milligram per kilogram over 10 minutes, which is very similar to the infusion we discussed earlier. And again, if conversion didn't occur within 15 minutes after completion, then they would get another infusion of 2 milligram per kilogram over 10 minutes. Now, if by that point, no conversion was achieved by 30 minutes after infusion conclusion, then electrical cardioversion was offered. Now, looking at the procainamide protocol, So they dosed at 15 milligram per kilogram, and they maxed out at 1500 milligram over 60 minutes. Now, I do want to dial in on this infusion time just a little bit. So what we might often be more comfortable with or see more commonly is an infusion time over about 20 minutes. And so it's not to say that what they did was wrong here, because if you look at their Canadian guidelines, they actually recommend doing an infusion over 60 minutes, but definitely differs from some of our United States practice here. And so similarly with Procainamide, though, if they had achieved conversion to sinus rhythm before the completion of the infusion, then they would stop the infusion. And then again, if no conversion by 30 minutes after infusion conclusion, then they would go on to the electrical cardioversion. So looking at the study endpoints, so primary endpoint being conversion to and maintenance to sinus rhythm. And then our secondary endpoints are very common ones that we've seen in some of the previous trials, such as time to conversion, need for electrical cardioversion, disposition, ED length of stay. And then I do like that they had this other kind of subgroup of secondary endpoints, such as return ED visits at 30 days, which we'll talk more about later, as well as a stroke, death, and return to normal at 30 days as well. So it's interesting to see how they had these longer term outcomes in this trial. And then your safety endpoints were your very common adverse events that they're watching out for, either because of the infusion or for electrical cardioversion. So for their statistical methodology, they used descriptive statistics for their baseline characteristics. They used regression analysis, and then they used Cox proportional hazards for their survival analysis. For their sample size calculation, they used a 15% absolute difference, which was the way they determined that was by polling the clinicians that were involved in the study, which I thought was kind of an interesting way to come up with that particular number, because it isn't necessarily that they grabbed it from the literature specifically, but seemed to rely more on clinical gestalt. And so when they did their power analysis, though, they looked at about a 65% conversion rate, which I would say seems pretty reasonable for Vernakalant, because if we look at our spectrum trial that we talked about previously, the lower end of the confidence interval for that was around 65%. So I felt like that was pretty reasonable to use. Looking at our baseline characteristics, I think overall, when we look at this, that they're pretty evenly split between the Procainamide and the Vernakalant group. And when we look at our mean age and our percentage of males, so we're looking at our low 60-year-old range, and then about 2/3 being male. Again, that kind of makes sense given that our general population of AFib is going to be male, and they're going to be older, in the 60-year or older range typically. Now, the thing I did want to point out, if we look at the heart rate, again, with this trial, the heart rates were kind of on the low side here, where Procainamide on average had about 109, Vernakalant had about 114. And it's really interesting because if we look at the RAFF4 trial, who also had the same author, their average heart rate was 115 beats per minute as well. So it was very interesting to see that both of these trials tended to have lower heart rates. And again, heart rates that we wouldn't really consider the patient to be in a rapid ventricular response. So it's interesting how that played out here. Otherwise, though, systolic blood pressures were the same, both about 130 millimeters of mercury, and about 2/3 of patients had a duration of AFib lasting less than 12 hours. So now, to get into the primary and secondary results, we'll see here that conversion and maintenance of sinus rhythm was statistically significantly different for the Vernakalant group, so 62.6% versus 48.8%. And of course, linking it back to some of our other trials that we talked about, Procainamide, again, falling within that 20 to 70% conversion rate. So this kind of falls into what is expected clinically when we looked at Cardioversion, Volkmann, and Steele. For Vernakalant, that's 62.6%. Again, we're seeing pretty similar conversion rates, especially when we're looking at that lower end of the confidence interval from the spectrum study. So these results are kind of expected. Now, if we look at the conversion time, Vernakalant did also do better in this particular group as well and was statistically significant. So they had at about 20 minutes. Procainamide had about a 45-minute conversion time. So Vernakalant was about half that. And again, going back to those other trials where we look at Volkmann and Steele for Procainamide, they saw conversion around 30 to 60 minutes. So this time frame makes sense. And then similarly for Vernakalant, this is maybe a little bit longer of a conversion time compared to the other studies, but again, right around that time frame as well. Now, need for electrical cardioversion, while not statistically significant, we did see a trend toward decreased need for electrical cardioversion with Vernakalant. Overall, ED length of stay was about the same, so not much difference there. And going into the 30-day follow-up outcomes, again, I thought these were very interesting outcomes to include into the trial. So they looked at return ED visits, and for both Procainamide and Vernakalant, really no difference between the two there. And then for return to normal daily activities, where we look at procainamide and vernakalant again, about the same, almost identical. 0 strokes in both groups, 0 deaths for procainamide. And to be noted, there were 2 deaths in the vernakalant group, which the authors described was not necessarily related to the study drug itself, but rather they stated that it was one death was due to sepsis and the other death was due to cancer, but not related to vernakalant, but did fall in the vernakalant group. And now looking at the adverse events for procainamide versus vernakalant, so we see about a 25% adverse event rate for procainamide and a 17.4% vernakalant adverse event rate. So you may be looking at this data and going, wow, that's a very high adverse event rate for vernakalant in particular. Because again, going back to that spectrum study where we saw maybe a 1.3% adverse event rate, this is absolutely blowing that out of the water. And so my theory behind this is we're including a lot of different adverse events, not just from the infusion itself, but now we're tacking on electrical cardioversion and sedation related to that as well. So I think naturally that addition tended to drive these numbers up when comparing it to other studies like Spectrum, for instance. And so when we look at the breakdown of the different adverse events, so you'll see that unfortunately for procainamide, it got plagued by hypotension again, being the most common adverse event at 8.7%. Otherwise, relative split between ventricular tachycardias and bradycardias. Vernakalant had a overall bigger split between the different groups where atrial tachyarrhythmias were the most common for this, but then also saw some hypotension, some bradycardia as well. And so the other thing that I wanted to point out with this particular side, that if we look at the cardioversion events, I like to point out the jaw thrust because they had a 2.9% versus 1.7%, which relatively low, but it's really more so on the very low side, I think, than what we're commonly used to when we procedurally sedate somebody for a cardioversion. So that could lead to different practices and potential sedation, which could eventually have outcomes on the study as well. Now going into the strengths and limitations, I thought a lot of the data that was presented here was very good and very interesting. I think their strengths were that they were a prospective RCT multi-center, which is great for that generalizability. They had appropriate patient-centered endpoints. It makes sense that conversion to sinus rhythm and time to conversion, I think, are patient-centered. I would imagine that living in AFib is not very comfortable in getting out of those rhythms, and to normal sinus rhythm would be something that the patient would be very happy to do. They also looked at this 30-day endpoint for thromboembolic complications, which I enjoyed that they added quite a bit, especially considering that when we're doing these cardioversions for these patients and then we have that atrial stunning, that we're actually going to have a higher thromboembolic risk. So it's nice that they included it, and also very nice for both of these drugs that it was basically non-existent in both groups. And then baseline demographics, I felt they did a very good job with kind of mirroring the typical, older male population that's going to present with atrial fibrillation. But now on to the study limitations. This was an open label design, which the investigators had cited they did on purpose to make it more generalizable and make it, mirror real world practice more closely. I thought that was an interesting way to put it, that you can make the argument then, why do we, not do every single trial open label? Why are we blinding any trials at all? So I think that could have opened up some bias potentially. For the variable infusion time, as mentioned with the procainamide, I think we're oftentimes very used to that 20 minutes infusion time, whereas they use the 60-minute infusion time here. Again, they had a basis for using that particular time point, but maybe you can make the argument that the slower infusion times, were they making procainamide less effective, potentially giving vernakalant an upper hand here? It's hard to say. And then otherwise, they use procainamide as the comparator. Going all the way back to the beginning of this presentation where we look at our own AHA guidelines, procainamide isn't really a top-tier choice. It tends to fall more towards the bottom, especially compared to butylide, flecainide, and amiodarone. So it would have been really interesting to see it. They compare this against something like amiodarone, which, going back to the Kochi-Adaka study, had nearly an 89% conversion rate. Would vernakalant have done just as well? Hard to say. And otherwise, the big issue with vernakalant too is that it's not yet available in the United States. So it's very possible that had it been approved tomorrow and we had it available for clinicians, that there'd be a certain degree of uncomfortability and unfamiliarity with it compared to our Canadian counterparts who maybe have more experience, where we're going to probably get a lot of a lot of differences in the generalizability with that here in the States. Otherwise, there's a small percentage of patients of AFib that were in AFib for greater than 48 hours. Again, it may be difficult to extrapolate this particular data for that subset of patients because there's that possibility that maybe the longer they're in AFib, the more difficult it would be to get out of that rhythm. And then lastly, I want to talk about the baseline vitals. Going back again to this trial for RAFF4 and even RAFF2, their heart rates were kind of on the low end when we think of the kind of patients that are coming to the emergency department with AFib, about 115 beats per minute. These patients weren't necessarily in rapid ventricular response, so it's hard to say how they'd fare or how Vernakalant would fare if they were. Again, you can make the argument that based on its very unique mechanism, that it has a higher affinity for its receptors at a higher heart rate, that it would actually fare better, but really no way to know that based on these baseline vitals. But nonetheless, overall final conclusion based on this paper, that when they've compared Vernakalant to Procainamide, that Vernakalant had higher conversion rates, shorter conversion times, and then the trend towards decreased electrical cardioversions. Adverse event profiles, relatively similar, potentially a little bit more for Procainamide, and Procainamide definitely was plagued by that higher amount of hypotension, which again was to be expected. Now, I always like to do a little bit of what's kind of coming into the pipeline. So I had a little bit of future research that's kind of coming our way. So one of them is looking at Vernakalant versus amiodarone for postoperative AFib. I think that's going to be a really great trial to see. And I'm very excited to see what the outcomes of that are, especially considering that I'd love to see how that would have compared to our first line options like amiodarone or flecainide or butylide, et cetera. Similarly, the other trial, Vernakalant versus flecainide, they're going to be looking at atrial contractility measured by echo. I think that'll be another excellent study that's going to be coming to market soon. So that way, again, we can compare Vernakalant and see how it really stacks up against a lot of these other first-line agents. So overall, very excited for that. That is the end of my presentation. Here are my references. Thank you, and what questions do you have for me?
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.